just
It's
dropping like flies.
it's
So
aggressive.
everybody's
Aggressive.
wearing a
It's
mask.
aggressive. Lots of upper respiratory tract pathology. That's for sure.
Knock on
And
wood.
lower respiratory tract. All right, guys. We're at noon, so I'm going to go ahead and get started. Welcome to our Department of Internal Medicine Roy Benke Grand Rounds. On this Thursday, we have our STAR Program Director from Gastroenterology. That is Dr. Camille Thelin. Dr. Camille Thelin is originally a political science major and with a minor in Hispanic studies at Boston College, where she graduated from that outstanding Jesuit institution. Camille then moved on to the LSU School of Medicine, where she completed her studies with graduation with honors. Went on to LSU for her internal medicine, where she was the intern of the year. So for all those interns of the year out there, that includes me, Dr. Mateja. We also have company with Dr. Thelin having that intern of the year award. So after she completed her internal medicine at LSU, she went to Tulane, where she did her fellowship in gastroenterology and hepatology. 2 years on faculty. She was at Tulane when we stole her to come to the Tampa Bay area in June of 2019. It didn't take long for her to find her way to leadership as she became program director, taking over for Dr. Shea in June of 2021. Dr. Thelin's accomplishments include, already in her short time here, her administrative accomplishments, becoming the director of USF Women's Digestive Health Program, as well as the co-founder and the co-director of the USF Health Neurogastroenterology and Motility Center. Dr. Thelin has already spoken at 3 international conferences, and in her short time as faculty already is in double-digit peer-reviewed publications, including a recent chapter in Gastrointestinal and Liver Secrets Plus, her chapter being on GERD in that. Things you may not know about Dr. Thelin: she was actually a resident assistant, an RA at Boston College. So clearly we can see where her program director skills started with trying to keep a bunch of college kids in line in the dormitories. She's also a certified yoga instructor and a clinical pianist, having won the Musician of the Year in 2000. And also, to show her well-roundedness, was on the intramural swim club at Tulane. So we truly have a Renaissance woman in Dr. Thelin, and we are very proud to call her our program director in gastroenterology. And Camille is going to give us a fantastic talk today on chronic abdominal pain, current and novel treatments. So with that, Dr. Thelin, take it away.
Thank you, Dr. Lizama. That was an amazing introduction. You can come with me anywhere. All right, everybody. So we're going to talk about chronic abdominal pain, which is essentially my bread and butter at the Neurogastromotility Clinic, which is a multidisciplinary clinic with GI surgery, me, we have a nurse practitioner. We are in the midst of getting our nutritionist, because we had one, but she left in October, and also GI psychology. So we're really blessed to have a multidisciplinary team that is growing. Today's objectives are to look at the current treatments to treat abdominal pain and IBS and other disorders of gut-brain interaction. I kind of bounce around with the terms, whether it's functional, DGBI, FYI, DGBI is probably going away because it's a mouthful and nobody likes it, including patients. So maybe more to come on room 5. And then also looking at kind of some new pharmacologic, but also non-pharmacologic treatments for chronic abdominal pain and IBS. And you can extrapolate a lot of this stuff to other types of pains as well, too, including pelvic pain. So the patient physician cycle when it comes to chronic pain is a vicious cycle. It's one where the patient shows up, expects a cure, unrealistically, right? Because they've probably been to a lot of other physicians before you, including some really, really well-known centers. They're requesting urgent visits and tests, which probably have already been done and don't really need to be done. The physicians become drained and biased and are really kind of in this organic etiology focus, and we sort of forget to look at the patient holistically, which can happen to us. And that sort of interaction with the patient is draining, I know personally. And then you send them for more things, which cost more money, which leads to higher healthcare costs and potentially iatrogenic harm and other referrals. And it's a process that just keeps going. Then the patient's dissatisfied. There's pessimism. There's maladaptive coping. There's lack of control. There's manipulation on the part of the patient. There's misunderstanding of what your role is and what their etiology of their disease is. That leads to catastrophizing. That leads to anxiety and hypervigilance. And then the cycle just repeats. So the reason I show this is that I'm well aware, because I'm in this cycle with most of my patients. And what I do initially when I come in, and the first visit's longer, obviously, but what I teach to the residents and the fellows is you've got to do a lot of work up front, and it's going to pay off eventually. But you really have to kind of set the stage. And the stage is, I'm not a magician. I'll actually say that to patients, like, I'm not a magician. And if there was one drug that could fix this, you would have been given that drug already. And I set the expectation because otherwise they're going to continue doctor shopping and they're just going to keep bouncing around and they're going to hammer you with my chart messages of dissatisfaction and misunderstanding. So, and I'm not like, this is not to say that I'm a pro at it. I currently am engaged in a everyday multiple message back and forth with a patient who's demanding to see me, who has just seen me and then got a scope just recently, like in the last 4 weeks, has already seen referring physicians as well too. And it's just like constantly. So again, this is also for me too. All right, the known pharmacotherapy, I'm not going to belabor the pharmacotherapy that we have. I'm providing you with a really nice little guideline that summarizes the American Gastro Association and the American College of Gastro Association for the pharmacotherapy in IBS, whether it be diarrhea, constipation, or just kind of generalized things. So this ranges from the diarrhea from allocentric, loperamide, rifaximin, aloxadoline, and it shows you in red the ACG recommendations and in black the AGA recommendations. And then it also shows you the quality of evidence for each and whether there's abdominal pain. I will point out that aloxadoline does not have abdominal pain relief, while it is a strong and conditional recommendation for diarrhea, whereas rifaximin does, and that's most likely probably because it helps with abdominal bloating and distension, which decreases all those nerve fibers from being activated. On the IBS-C side, we've got linaclotide, tenapanor, which I'm going to talk about. It's the new kid on the block. Plecanatide, lubiprostone, tegaserod, which you have to have an IND for currently right now in the United States, and then PEG laxatives. So all of these on the IBS-C side actually have an abdominal pain relief of yes, whereas PEGs don't. So just be aware that you're just changing the quality of the stool with a PEG laxative. You're not doing anything for their pain. And so usually that's a patient that you'll have to have an additional adjunct agent. And then there's peppermint oil, which is great, but can cause reflux. So it's got low and kind of conditional recommendations and low evidence. There's antispasmodics, which we use a lot of, bentyl, hyoscyamine, you name it. Tricyclics. Love tricyclics. We're going to talk about them in more detail. I'm hearing that must be someone's mic, sorry.
Yeah,
and then okay.
If everybody could check. Okay. Yeah, if everybody could check, mute their mics. Thank you so much.
Thank you. And then SSRIs. Now, I do have a longer list. I'm going to get into the neuromodulators, so don't worry. I just think that a lot of this stuff is a separate discussion. It's not a chronic abdominal pain management discussion, but I wanted to provide you with this lovely table that you can go to and just to kind of give you an overview of all the drugs that we'll use. The majority of them of these we use to change the quality of the stool, although you can see that there's abdominal pain relief. So if you could get 2 birds with 1 stone with one patient, wonderful. It is unlikely, though, especially in a tertiary coronary center, that we're going to get a patient that's going to be that simple, where I could just throw a little Linzess. 4 to 6 weeks, you got a little neuromodulation because it's a GC agonist. You downregulate CGMP, and boom, you get decreased afferent pain fibers, and they have less pain. It's unlikely. That's already being done in the community. So now we're getting patients that have failed those things, and what do we do now? And that's what this talk is about. So this is a nice little clinical decision-making tree. Again, just a big overview, separating, talking about education over and reassurance, lifestyle modification, dietary modifications, which we try to do with all patients, right, in any situation. And then we get into the, maybe we're going to start meds. So on the C side, we usually start with PEGs. Then we get into the abdominal pain side. I'll talk more, like I said, about the neurogut modulators, and then you get the secretagogues, and then you've got tegaserod, which you need an emergency IND for in the States now, and then IBSD on this side, just kind of over-the-counter stuff again. Abdominal pain, very similar. Rifaximin, low-dose TCA. The reason low-dose TCA is on this clinical decision tree for IBSD is because you've got a side effect, right, as an anticholinergic that's going to thicken up those mucosal everything, including the stool. And so again, 2 birds, 1 stone, the abdominal pain, the diarrhea, that might be all you need from that standpoint. Okay, and then here is the bread and butter of this talk, right? What do? Do you switch meds? Do you do SNRIs? Do you do brain gut behavior? Do you think about hypnosis, vagal therapies, etc.? So let me just take a brief on the secretagogues and let you know about this new kid on the block called Ibsrela. So your secretagogues are all going to be essentially just creating like an electrical sort of homeostasis where they're manipulating an ion. And by manipulating an ion, a negative one usually, then you're manipulating the positive one that would have followed. Most of the time it's a salt, right? And if you retain the salt in the gut, then you retain water. Ergo, then your stool's softer, and that soft stool is going to create peristalsis, and that's going to create that fluffy bowel movement spontaneously that we're looking for. The nice thing about linaclotide and plecanatide are that they also activate that they're GC agonists, and so they activate CGMP. And eventually what ends up happening, and it doesn't have it on here, but you're going to downregulate those pain fibers like I talked about. And so over time, usually about 6 weeks is when you start to see that pain scale goes down if you're doing like a patient-reported outcome. Tenapanor's different. It's the newest kid on the block. Both these, all 3, whether it's Linzess, Trulance, or Amitiza, right? And I've put the generic names here. They all act on a chloride receptor, whereas tenapanor doesn't. It's the first in class. It's a minimally absorbed small molecule that's acting on a sodium hydrogen exchanger. And it's just maintaining that salt-water balance like we talked about. In a double placebo study, 26 weeks, the primary endpoint was to see whether or not there was a decrease in the worst abdominal pain that the patient had for at least 30%, and an increase of at least 1 complete spontaneous bowel movement. And they met both of those, and they wanted to meet both of those in the same week. So they achieved the primary endpoint versus placebo. So you can see here 27 versus essentially 19%, 18.7. And they also had improvement in their abdominal symptoms and global IBS symptoms versus placebo. So it is used. We do prescribe it. It goes through a prescription, like a specialty pharmacy. And we have several patients that do very well. The side effect of these is very similar to all the secretagogues, explosive diarrhea. That can wane after 3 to 4 weeks. So I don't immediately stop. I just tell patients, hey, good, things are moving. Like it's a little too excessive. Maybe we down dose, or we thicken up your stool with something like a little Metamucil or a little psyllium, or we break open, and instead of doing every day, we do every other day or every 2 days. So there's a lot of manipulation that can happen here. As far as neurogut, so this is the last of the secretagogues I'll talk about, because now we're getting into the neurogut modulators. Why do we use neurogut modulators? Well, it's improving your brain's pain regulation, and obviously it's an enteric nervous system that's connected to the main nervous system, right? So it's just a series of highway. It used to be that we thought they were, super separate. We know they're not. And so what we're trying to do is modulate peripheral effects on motility and secretion, but also reducing the nerve signals. And I liken it to, well, if a tree fell in that forest, forest being your abdominal cavity, and you didn't know, well, great, it doesn't matter. Like, let's move on with our lives, right? Because we've already ruled out, you've had 1,000 tests. This is not cancer. It's just poop that's not moving or too much or SIBO. And, you know, you look 9 months pregnant, but in the grand scheme of things, are there other things that are more important? Probably. The problem with this, and there may be a little bit of neurogenesis as well too, but the problem with it is that evidence-based medicine is super limited because we don't really have controlled trials for a lot of these things. And then it's integrated with open label studies and case series. So mainly it's just expert consensus that's led us to this and essentially like clinical experience. So take our word for it is what I have to say about that. The way we look at it is, again, this kind of model of the patient-physician relationship is the biggest and most important thing, and that's why you've got to do all that upfront work. And then you look at whether or not you're going to do adjunctive therapies like the behavioral health referrals that you see on this side. And that can range from CBT, mindfulness, hypnotherapy, psychotherapy, or psychiatric referrals on this side that we use. And we do tend to start with TCAs. And I'll go over how we do that. We start low dose, increase every 4 to 6 weeks, and then augment. I just do check-ins, honestly. I just tell patients, like, how are you feeling? Are you snowed in the morning? I tell them to take it at night. Most of these people have a lot of anxiety. They're not sleeping well. So again, now I've got multiple birds that I'm killing with one stone. They're taking it at night. They sleep better. If they're not super, super sluggish, lethargic, you know, walking around like a zombie in the morning, that's a good dose. Keep them on it for about 4 to 6 weeks. And then again, another check-in. And I try to do a lot of that because I'm trying to teach them, like, you're also responsible. Like, it's not just me. You're responsible for keeping me up to date with what's going on. If you don't want to take these medicines and you want to go doctor shop, that's fine. But this is not how this relationship is going to work. So I tried to set that from the get-go. And then obviously combined, and we'll talk more about that. This is like our little, you know, our go-to. I know I showed you that other algorithm, but this is one of the best algorithms that we've got. Dr. Drossman is, you know, he has been around since Rome 1. He is responsible for a lot of what we're doing. We start usually with the TCAs as the first line treatment, mainly because pain tends to be predominant, and that's what we're focusing on here today, right? We do use tetracyclic antidepressants often, but usually as an augmentation, and that's when patients have nausea, vomiting, maybe some disturbed sleeping as well too. SNRIs, usually when there's some reason that you couldn't use a TCA is when I'll hop onto SNRIs, or maybe there's another pain component that is mainly treated with this, but not completely. So I might augment with an SNRI. And then SSRI is mainly when you've got somebody who's got a phobic feature and you can't ignore that. Like, you can't ignore the patient who comes in and is exhibiting OCD behavior. And you can't ignore the patient who is so anxious that they're crying, they can't get words out. You're never going to be able to treat the chronic abdominal pain if you don't address that elephant in the room. And again, that's the main thing, right? They think it's the abdominal pain, but that's probably driving everything. As far as, you know, is there an issue with using a lot of these together? Really, we use a lot of these at low doses. If I ever feel uncomfortable because someone's on a myriad of things, and including maybe some antipsychotics as well too, psychiatry comes in and we talk together, or I'll talk to the patient's primary psych person as an outside provider. We will use as a parents as well, like buspirone. So Buspar is used a lot when patients have anxiety. I'll use delta ligand, gabapentin, pregabalin, et cetera, when there's a lot of like nerve, abdominal wall pain, atypical antipsychotics. I talked about that. I usually use these in a situation where there's nausea. I'm using a lot of olanzapine in my gastroparetics now because the Zofrans aren't working, or they get constipation with those, the 5-HT4s. And then psychological treatment, which we'll get into for sure. Can't do this without them. Why do these work, and why are TCAs our go-to? Well, look at this. Look at all the things that it's hitting, right? Like, look at all the different pharmacologic receptors. So you've got noradrenergic and histaminic and muscarinic and 5-HT. So you're hitting so many more receptors with tricyclics. It's an old drug. It's a great drug for this. It's not a good drug for antidepressant because the doses you need are like 200, 250 to change that. And that's not something we're ever going to get to. I mean, I start people on like 10 and I tell them to cut it in half and maybe cut it in a fourth if they're really hesitant. 2.5. 2.5 of the TCA isn't going to do anything, right? But I'm just slowly walking you and wading you into the water. And again, we do use some of these other agents, but I just want you to see this visual so you understand why TCAs are the go-to for us. Augmentation treatment, I talked about it. Using another treatment to enhance benefits. You can use lower dosages of these, which is why we are not so nervous about combining a lot of these things and reaching a level where you've got serotonin issues. Helpful when one of your treatments isn't as successful or produces side effects. And so maybe I'll lower something and I'll say, you did have some symptoms that got better, but then you had some side effects. So maybe we don't give up completely here. We add something to augment in the areas that we have not achieved yet the control that we want. For my patients, this is usually where I'm already at from the get-go because these are patients with refractory GI disorders. So for example, you can add a TCA or SNRI to a peripheral GI agent, right, that you're using. So this is like the TCA with the Linzess or the TCA with the Amitiza or the TCA with the Tegaseron, which is Ibsrela. You can add a delta ligand to a TCA or an SNRI if you've got abdominal well pain and they keep pointing to one area and maybe you thought about a nerve block and they improve, but they don't want to get nerve blocks consistently. You can add bupropion as an antidepressant, which will also help their anxiety. You can combine the SSRI and the TCA for better pain control. You can add an atypical antipsychotic like quetiapine or olanzapine. If you've got somebody who's got really, really, really poorly controlled nausea as well too from their pain, and then the psychological treatment as well. We use patient-reported outcomes. I wanted to briefly mention it because, yeah, they're burdensome, but what do we have? We don't have pathology, right, in my area. So you've got to have some type of measurement and information systems. So the majority of the studies I'll talk about when it comes to the novel treatments do a lot of these patient-reported outcomes. So just wanted to briefly just kind of show you how many we have. And there's definitely more. Mirtazapine and IBSD, why do I use it? Well, mirtazapine is a great agent for minimally thickening up your stool. Yes, you can get drowsiness, dry mouth, fatigue, and yes, there's weight gain, unfortunately. But if I can control your symptoms and again, achieve multiple symptom management, that's what I'm aiming for. In an 8 double-blinded RCT, 44 was the mean age, 38% were female. The placebo group versus the 62% female in mirtazapine, you can see the response, obviously, right here. And this was at a 15 milligram dose for a week and then a 30 milligram dose. Now, this might be a little higher than I would start patients. I'd probably start them on a 7.5. Especially my patients, they also tend to be a little worried about their weight. Maybe there's some ARFID component to it. But you can see that in the symptom reduction, there was a change from baseline to end of treatment. It changed greater than 50 points from baseline at week 8, which is wonderful. So 61% to 30, as you see. And then there was improvement in pain frequency, bowel dissatisfaction, abdominal distension was not improved. But distension's different, and it's usually a superimposed issue like SIBO or EMO. The stool consistency improved, anxiety, and then the quality of life. Again, we discuss side effects with them, but usually at this point, they're ready to deal with the side effects. Pregabalin, as far as efficacy in IBS patients, this is a double-blinded study with patients that had greater than or 3 pain attacks per month. They took a dose of 225 versus a placebo BID for 12 weeks. Mean age was about 40 years, 86% were female, 44 had IBSD, 35 IBS-M and 21 IBS-C. Pregabalin had the lower average of the pain scores around week 9 and 12, as you can see here. So again, it could be used. There were some differences in the Bristol stool scale for diarrhea as well too, and that's just part of the side effect profile. So again, this could be an adjunctive therapy. So this is me just discussing sort of some common adjunctive therapies that will add to the basic gut modulators. So overall general recommendations for DGBI, lower modest doses of TCAs are our go-to initially, provide the most convincing evidence for benefit for treating the chronic pain and painful functional GI disorders. SSRI is also recommended, but all the other things I talked about can be too. Augmenting, and that's the adding of the second agent, is recommended when a signal med is unsuccessful, or you can't, or you're getting side effects at higher doses from the other ones. That doesn't mean completely cut it out. It just might mean decrease and then look for something secondarily. And then again, you want to continue the treatments. A lot of patients will come back and then finally I tell them, like, give me a good 6 to 12 months. And they get despaired, but I'm like, look, you came to me in your 60s, give me 6 months at least. Let me try to help you. And then they get to the point where they feel better and they'll say, can I stop it? I'm like, ah. So I have the conversation of, you could, but you're probably going to get back to where you were. Maybe we could talk about decreasing some doses or trying to simplify the med regimen. But I'm not a big fan for decreasing a lot of the agents that have been implemented for these patients because it's taken such a long time. And then finally, talking to them, especially in the beginning, and optimizing the patient-provider relationships. Now we get to the novel, cool therapies. So histamine's been looked at, specifically Avastin, to reduce pain in IBS. And it is thought to sensitize one of the nociceptors that we have. It's TRPV1, and it's a transient reporter potential channel V1 through your actual histamine 1 receptors. The study looked at 55 IBS patients, 62 were female, the mean age was 35, and they either had Avastin, which you see right here as the dotted line, versus the placebo. And it was a 12-week trial. Most patients with Avastin had at least considerable relief of symptoms, so 46 versus 13%. And there was a gradual and significant decrease in abdominal pain scores compared to placebo, with a p-value of 0.004, and their quality of life scores showed improvement. Why histamine? Well, this is, again, another topic, but there are a lot of degradation products in the wall mucosally, mainly mast cells, and this is probably important in that patient population. They didn't look to see whether or not these patients had mast cell deposits, and that honestly would be the next step. Like, let's biopsy, what are the levels? Can we decrease the levels of mast cells? Is this something we should think about? That's a whole other study. Anybody interested, let me know. Proposed mechanism of action with allorinab. This is another agent. It's a peripherally acting full agonist of a cannabinoid receptor, number 2, and it's activating multiple cell types. So not just in the gut, but epithelial wall cells, immune cells, and afferent nerves of the GI wall. And the thought is that it could contribute to attenuated action potentials. And so if you decrease the colonic nociceptor action potential, you thereby decrease the pain reduction that's relayed to the brain. Again, most likely why we have a lot of patients that are also using CBD as part of their pain management. This is a clinical trial, and I'm sorry, let me move that. I apologize. Clinical trial looking at allorinab. It's in a phase 2. So they looked at abdominal pain, 12-week, 2-week follow-up, placebo-controlled parallel group study, placebo TID, or 50 mg TID, or 25 mg TID, or 10 mg TID. On the side, you'll see the inclusion criteria and the key exclusion criteria. I'm not going to go through those. The AAPS is something called an average abdominal pain score. Again, another PRO. And to evaluate what they were looking at, the primary endpoints were to evaluate the safety, tolerability, and efficacy of this with IBS experiencing abdominal pain. And the results were submitted in August 22, quality review also in August 22, and then resubmitted. And essentially 50 milligrams seemed to improve that average abdominal pain score in patients with moderate to severe pain. So we may see another agent coming out that we may be able to prescribe. All right, moving on. Glutamine. I have a lot of patients that come to me and talk to me about glutamine. So glutamine versus placebo. This was in post-infectious IBS diarrhea patients who are thought to, the explanation of post-infectious is that there's this increased intestinal permeability. Why? Because, well, something has affected probably the tight junctions, right? When you think about the epithelial wall, it's quite complex. It's not super simple. There's tight junctions, there's occludens, and being sick and ill and being immunocompromised can affect the mRNA of these, and being on a certain diet can do the same. And so I liken it to, even though we hate the term leaky gut, if you pull back and try to explain to the patients, it's not, you don't have a hole in your gut, that you'd be septic and dead there. So, but it's more complex. It's cellular and molecular. And we are influencing how many guards are at the door between your cells and intramucosally and extra. So things are talking a lot more and things are passing through. And it's such a complex system that you can imagine that there's more things happening. So what they looked at was glutamine versus placebo. 54 went in the glutamine arm, 52 in the placebo arm, and they just used whey protein powder in these patients. 8 weeks, 5 grams TID. They reduced all the secondary endpoints. So IBS symptom score, 8 weeks, 301 versus 181, p-value good, daily bowel movements, 5.4 versus 2.9, Bristol stool scale, 6.5 versus, so all the p-values and the intestinal permeability, which they measured not by doing any kind of biopsies. They measured secondarily as a surrogate, looking at elevated urinary lactose and mannitol, right? Lactose and lactulose, and mannitol are large sugars. Are we passing them in the stool or not, in the urine or not, based on that intestinal permeability? And then what they found was that they were able to normalize the ratios of this elevated urinary lactulose and mannitol ratios in the patients that got glutamine, making us think that we have improved the intestinal permeability versus the control group. Again, more studies have to come. Adverse events were low, no serious issues, and then really honestly now we need new large RCTs. But you can see that this was their endpoint, and there was a big difference in those symptoms that we talked about, in the endpoints we talked about. This is every single one of these, so you can see down, 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 down post-glutamine. So this is just those separate sections that I spoke about for that one. Now we get into the cool area of vagal nerve stimulation as an anti-nociception. The main thing is that if we can decrease this noradrenergic, serotonergic modulatory fibers that are going away, right? If we can decrease that to the dorsal horn, can we maybe decrease and block that spinal afferent from coming back up? So we're trying to modulate the fibers from the brainstem centers, and hoping that by doing so, we can alter the sensitivity of your dorsal horn, and thereby changing the way that your afferent pain fiber talks to your dorsal horn. And then again, it doesn't go to the brain thereafter. So that would be the point in looking at trying to inhibit the second order nociceptive neuron. So how does it work and what do we do? And also, sidebar, there's also some reflex circuitry that's involved in immunity and inflammation by activating the vagal nerve. So there's decreased tissue injury that can happen mainly because vagal nerve stimulation is inhibiting pro-inflammatory cytokine release. So it's got a twofold effect. And how does it work? So it's either handheld or it's implantable devices, which we have with gastroparesis, or it's non-implantable. And this specifically is called the peripheral electrical nerve field stimulation device, also known as IBS STIM. And I'm just going to skip to that and then go back. I just wanted to show you. So this is called IBS STIM, but essentially it's the same thing. It's a peripheral electrical nerve field stimulation. So how does it work? It's creating this field effect by targeting all of these auricular branches of several cervical cranial nerves, and specifically this auricular branch of the vagal nerve. And what they're trying to do is modulate those central pain pathways that are accessed through this peripheral stimulation that innervates the external ear. And again, blocking that pathway from getting to the higher brain centers. This is only FDA approved for children currently. There is a big study at UCLA that is currently going on with adults. Here they delivered a 3.2 volt alternative frequencies at one MS pulse of 1 hertz or 10 every 2 seconds. The battery life was 5 days, and it delivered a stimulation of 2-hour cycles. There are multiple little teeny tiny needles that are 2 millimeter or 1 and 1.5 millimeter that are inserted in the dorsal and the ventral aspects of the ear, and also in the vascular bundles here that are trying to create that field effect that I showed you here. Essentially, we are sort of firing off a ton of stuff so the brain's confused. I mean, that's essentially kind of what's happening. And it was so positive for these kids that were 11 to 18. They met Rome criteria for functional GI disorders, not only IBS, but also functional dyspepsia, abdominal migraines, and functional associated pepsia. And they were randomized 1-to-1 4 weeks and had active devices or a sham device for 5 days a week for 4 weeks. This is it. They just did a 4-week, and they had a positive p-value, and they did change the worst pain scores in these children, which is incredible. And here we look at some of the primary endpoints for clinical response: greater than 30% reduction in worse abdominal pain. Again, sham, no sham, no sham, sham, no sham. And again, same thing, the 104 kids randomized 1-to-1 for 4 weeks. So more to come on this, honestly. And I know we've all poo-pooed the vagal nerve for a long time, but it's all a nervous system. So, we have to change our thought patterns, and we're using it for a lot of other things as well, too. This is a adult study looking at transcutaneous auricular vagal nerve stimulation. So again, here, and also sham. So what they did is, and this is part of this adult study, 42 patients randomized either to the group, 32 were female, 10 were male, for 4-week transcutaneous auricular vagal nerve stimulation reduced their VAS, which is just a pain scale again, and by 64% versus the sham group, and by 69% versus baseline. And at 4 weeks, you had 95.2%, so 20 patients after their transauricular vagal nerve stimulation had greater than 30% improvement in weekly average daily scores from baseline versus 36.8 after the sham. And it increased their complete spontaneous bowel movements as well. And because of that, improves their quality of life and decreases their IBS symptom scores. So pretty amazing things that are happening with stimulation. Often I will actually tell patients, you can buy an over-the-counter handheld. There's a lot of stuff that's being done in neurology with migraine therapy as well too that's looking at this. So sometimes I'll get to benefit from what's happening from migraine therapy or other stimulations, which we're going to talk about, that are other brain gut behavioral therapies. Why does this work? Well, because you've got central mediated processes that are really just being sort of hyper manipulated because of all of these anxious tendencies, maladaptive coping behaviors, overactive responses, stress sensitivity, high cortisol levels with dysregulation, and all of that just leads to sympathetic nervous system arousal. So anything that we can do to increase that parasympathetic tone, whether it be mindfulness, whether it be meditation, whether it be yoga, whether it be hypnotherapy, whether it be CBT you're doing at home, along with potentially manipulating that vagal nerve sensation and just kind of blasting the brain with those signals is going to help the patient. So we use a lot of behavioral therapy options, and we have a GI psychologist, Dr. Rebecca Clam, as well too, who helps us do a lot of this stuff to try to decrease what's happening. These are the three arms. Here's your pain predominant, here's your anxiety, depression arm, and your GI specific anxiety. So we start all in the same level playing field: symptomatic medical treatment, lifestyle modification, stress management, and dietary changes. But then when we're pain predominant, we'll talk about those neurogut modulators like we talked about, and then we add the behavioral gut therapy. When you are someone who has a lot of co-related mental health issues, we either are co-managing with psychiatry or you're already on a neurogut modulator that's helping those things. And then at that point, we start to add behavioral gut therapy. And then finally, for patients that have mainly anxiety, this is the patient population that we'll send to hypnotherapy, acupuncture, etc. When you look at all of these, there's not one specific that stands out, right? They're all helpful, but there's not one that sits out against the others. So they're all helpful, they're all efficacious in IBS, but none of them are superior to another. And that includes group hypnotherapy, CBT that you did via the internet, face-to-face CBT, dynamic psychotherapy, stress management, stuff on the telephone, even contingency management, dietary and lifestyle advice, etc. So I'm sorry, dietary lifestyle advice was the only one that was on here, but that was our meta-analysis that looked at the psychological therapies for IBS. So I think this shows you that there's efficacy here, and it should definitely be part of the management in these chronic abdominal pain patients and chronic pain patients generally. There's a lot of, like we mentioned here, a lot of stuff that can be done at home. These are just but 5 companies. 2 of them are actually already covered by insurance, definitely Nerva and Mahana, and more to come on a lot of these as well too, that patients can download on their phone for free. They can get a little code in the beginning. A lot of us have codes that we can give them so they can see what it's like, and then see if they can afford it after the insurance has covered it. So I think there's a lot of cool novel treatments. My take-home points are that clearly you can use TCAs. Yay. From a diary standpoint, we did talk a little, just really briefly, about rifaximin and some of the other things that reduce abdominal pain, but mainly the neurogut modulators. There's less evidence for aloxidolene, which you had on that first lovely chart, and antispasmodics is needed. For IBS-C, we use the secretagogues that you see here, including the new kid on the block here, tenapanor, Ibsrela, which can reduce pain. Although maybe less efficacious, although they did meet their endpoints on the studies. Neuromodulators are our loves. TCAs are effective because they're gangbuster and they hit every receptor. And then we talked a little bit about SNRIs and tetracyclic antidepressants. I do tend to give mirtazapine a lot as well too, just because I have a lot of patients who are losing weight unnecessarily from nausea and vomiting from their pain. We talked about novel therapies and how these are showing promising data in reducing pain. And these were specifically directed towards the gut, and then the brain-gut behavior therapies that are usually added also as an adjunct to a neurogut modulator or some type of symptom-based treatment like these drugs that we know of, Linzess, Vyburzi, etc. And that's it. Questions?
Thanks, Camille. Excellent talk. Very, very good. Any questions? We should have a few out there for sure. Gastroenterologists and primary care physicians, I would think, may have some questions as to, especially the novel therapies that you were bringing up.
There's one in the chat.
I'll go for it, Jen.
What is the incidence of voice changes and difficulty swallowing with vagal nerve stimulation for irritable bowel?
I haven't had any discussions about or any issues with voice changes and difficulty swallowing in those patients. So I don't know what the incidence is. I can't tell you. I don't personally have any experience with any of those issues. Sorry, Dr. Henning. Amitriptyline, Joyce, amitriptyline is my favorite. It's the oldest kid on the block. And as you go up,
Camille,
yes.
Could you repeat the question just for everybody?
Oh, I'm so sorry. Okay, so did you hear the first one?
Yeah, we're good on the first one. How about the second one?
Is there a specific TCA which works better, amitriptyline versus nortriptyline? So I like amitriptyline. I go with amitriptyline first. However, sometimes I have patients who are peg fed or can't tolerate pills or some sort of pill aversion. So I use nortriptyline, or they tell me they tried it helped, but the dose is still too high with amitriptyline, and I can only cut it so small. So then I'll say, oh, guess what? Nortriptyline comes in a liquid. There's a suspension, so we can use a little dropper. You could do a cc. You could do a lick, like a 0.25 cc's. Anything to try to get them to start to break that cycle of that afferent pain loop that we've got. Yes, such a huge issue in primary care. Absolutely. Such a huge issue in GI generally, which is funny because, a lot of GI fellows come in thinking, I'm not going to deal with this. And I'm like, yeah, it's going to be 60% of what you see, even if you, especially as you go out into the community. But when we get to our ordinary and tertiary levels, it's just complex. Honestly, I just liken it to throw the spaghetti against the wall, whatever sticks, works. I'm glad. Yeah. I joke that it's prescription hug in my clinic. A lot of these people just need to be heard. Sometimes it's all they need. Sometimes that's all I did. I didn't really do much. I just listened to them. And we have to think a lot outside the box. I work a lot with, not personally, but their integrative medicine doctors, because they all have integrative medicine physicians. And I'm like, okay, let me not be so biased. Let me see, let me look on the back. A lot of the times they come in with these, 60 supplements that are costing so much money. And it's essentially, like, this is my favorite. They're taking something, it has aloe in it. And I'm like, well, this is why your constipation's better. And it's, aloe is an anthraquinone, which is what we find in senna. And we were able to take that organic compound and make it in tiny, tiny little pill. But if you want to buy aloe and core it out and spend a lot of money on actual aloe or these supplements, go for it.
Yeah, it's not uncommon for every medical student to hear when they started their primary care rotation that the most common complaint they're going to see in the primary care clinic is abdominal pain. And you very much hit, nothing has really changed over the last 30 years. It is the most common complaint that will be seen.
It is. It's the most common complaint. And I really, even though all of these other things are useful and used, I really think the main part of this is that relationship. And what you do on the forefront when you first meet that patient, and kind of drawing, not drawing lines in the sand, but just letting them know what the expectation is, what you can do. And, I say, look, we're going to move the boulder a little. You're going to see a little bit of dead grass. And every time we'll move the boulder a little bit more. And I'm like, if it's 10% with this and 11% with this and 9% with this, well, okay, you're already better. But nothing's going to magically fix it. Not one thing.
Correct. All right. Any other questions for folks? Very good discussions. All right.
All right, everyone. Well, you have my email. Feel free
I think
to.
everybody wants to get back to their busy wards.
I
and
know.
busy No, this has been great. Thank you, Camille, for an
Thank
outstanding
you.
talk. I appreciate, and thanks for all you're doing in all your leadership roles
Thank you.
at USFTI. Appreciate it. You all take care.
Thank
Bye-bye.
you. I put my phone number and my email in the chat for anyone.
Thanks, Camille.